very happy day to all. I'm Professor Sampoornam, and I'm basically a nurse, of course, psychologist, clinical psycho. I'm taking much work in suicidal clients. I'm a professor, nursing professor also. So in this evening, I'm just here to present a very small research paper along with the brain stimulation. Since this conference is purely related with the brain stimulation, I'll just start with the topics which are very closely related to brain stimulation. So in those days, some long back, we treat mentally ill patients with electroconvulsive therapy. Of course, you all know what is electroconvulsive therapy. So we create convulsion through shock. And some long back patient had pain also because of that shock. And later they modified that particular shock into a modified ECT, like giving atropine, succinylcholine, and thiopentone to relax the muscles. And after relaxing the muscle, they give shock. At present, ECT, they don't recommend clinically, of course. Many scientists, they oppose ECT, electroconvulsive therapy, because the exact action of ECT is unknown, literally speaking. And of course, the few scientists, they suggest that it's the catecholamine pathway like norepinephrine, serotonin, dopamine, GABA, glutamate in the brain. And few say that exact mechanism is unknown, so don't put patients under ECT. And at present, we do have an excellent new treatment called transcranial magnetic stimulation. And in abbreviation, it can be just put as TMS, transcranial magnetic. T stands for transcranial, M stands for magnetic, and S stands for stimulation. And this device was introduced in 1985 by Anthony Barker and their colleagues. And basically, this TMS can be put for 30 to 45 minutes. And patients can receive this transcranial magnetic stimulation 5 days a week. Suggestively 3 days. Still, we put patients for 5 days a week. In Indian setup, this TMS is really in rudimentary state. You all should know this. And in foreign countries, ECT have been banned and they've started TMS. And in India, still we put patients under ECT. And you can see the picture here. See, the lady is just comfortably lying in semi-fowler's position with the transcranial magnetic stimulation over the forehead of her. So it is just placed on the forehead. It's a machine, or it's a magnet, literally speaking, and it has been placed on the forehead. And the electromagnetic waves will stimulate the brain, electrical activity of the brain, and all these symptoms of depression will taper. At present, they recommend this TMS even for dementia or Alzheimer's patient, and many trials have been for even schizophrenic client, and it really works for depressive client and for the clients also. So regarding uses, you can observe that magnetic stimulation, it just stimulates the nerve cells or the electrical activity of the brain, and it scales down the symptom of depression. So you all may know the symptoms of depression like helplessness, hopelessness, worthlessness, very cardinal or very hard symptom of depressed mood, depressed validation, depressed cognition, of course, and suicidal ideations also. And like healthcare workers can just make the patient ready for a TMS, and you can just check for the order of TMS, and with all the parameters also you can check, like baseline parameter like their vital sign like temperature, pulse, respiration, BP, any pain, and of course a motor threshold or any other activity. We can just check, and basically this TMS should be given by a trained personnel, that you should understand. And the duration is very important, the 30 to 40 minutes or the 45 minutes, and all the pulses we check on and off, and the scalp, we just check for the scalp, whether it is really okay or not, and we check. And if the patient is really good in condition to receive this TMS alone, we start. And healthcare worker also can sign the informed consent form to receive the same transcranial magnetic stimulation. The patient, of course, the relatives should know what sort of treatment the patient is receiving. Patient, suppose he's developed depression, he may not know. Insight may be absent, but still relatives can just make all signed copy of informed consent or assent consent. Next slide, ma'am. Yeah, this is a very new treatment. Just now they've started, I could say, even in basically this treatment, in the sense external trigeminal nerve stimulation, ETNS, it stands. And in US, United States of America, FDA, Food and Drug Administration, they've just recommended and they've just permitted this marketing. And it's the first medical device to treat attention deficit hyperactivity disorder. So you all know what is attention deficit hyperactivity disorder. So children with attention deficit hyperactivity, they cannot stay in one place, very restless with fidgety movement, and they may have a very lack of attention. So this is because of some biochemical changes in the brain, and literally we treat the drugs basically. And the drug might be like dextro amphetamine. So as we just make dextroamphetamine, which acts in the reticular activating system, could be a very good drug, which acts against this ADHD. But still, what researchers they suggest in the sense this dextroamphetamine, it puts patient with some other side effects. So better to shift with ETNS, in the sense external trigeminal nerve stimulation. And it is basically recommended for children between 7 to 12 years, that too under supervision of caregiver who is really taking care of the client or bystander even. So it's like a very low level stimulation. It's not like TMS. TMS is high level stimulation we fix. And here, I mean, in the sense, it is fully magnet and it stimulates the brain nerve activity. And here, in case of ETNS, it is low levels, very low level stimulation. It just stimulates the brain's trigeminal nerve. So trigeminal nerve is very, you all know the branches of trigeminal nerve. It is in the face. That's why when a patient is fainting, we just pour some water in the face to just retrieve it back. So each night, this trigeminal nerve will be stimulated by ETNS, in the sense external trigeminal nerve stimulation. And electrodes will be applied in the forehead. You can observe the patient here. He's just having an electrode applied in his forehead over. You can observe. And it is again connected to that device, nerve stimulation device. And a patient can literally sleep for 8 hours throughout night, pleasant sleep he can have. This, this external trigeminal nerve will be stimulated by this very small equipment. And throughout 8 hours of 8 hours of sleep, the stimulation will be there. And regarding uses, you can just observe it for even depressive clients or even epilepsy clients or post-traumatic stress disorder adult clients. Especially, it is very, very useful for attention deficit hyperactivity disorder children. And here you should know something about post-traumatic stress disorder. Epilepsy you would have observed on and off in clinical picture. So post-traumatic stress disorder, in the sense, after an event, patient may develop many, they may receive. And this post-traumatic stress disorder has been removed from psychiatry. It has been removed from psychiatry in the year 2017. They say that when compared to psychic symptoms, most of the post-traumatic stress disorder clients, they develop all physical symptoms like cardiac problem and of course, problem in the lungs, visualized highly, and of course brain, especially they talk about lungs and heart, of course GA tract also, of course even kidney. So at present, in this post-traumatic stress disorder is treated in psychiatry also, but still in India we treat, I don't know about other country. In India, successfully we treat post-traumatic stress disorder clients in psychiatry, OPD also, of course in IP. And healthcare workers can also monitor the side effects like drowsiness, like any appetite change or trouble in sleeping, teeth grinding, headache, and fatigue, because these are all commonly reported in ETNS, external trigeminal nerve stimulation, especially drowsiness, loss of appetite, especially trouble sleeping, teeth clenching, and headache and fatigue are frequently reported side effects of ETNS. So since this conference is purely related with brain stimulation, I would like to highlight these 2 points about external nerve stimulation and transcranial magnetic stimulation. And next few slides will be about my research work. Yes, next slide, ma'am. Yeah. So it's a very small paper. The previous slide, ma'am. Yeah, very small paper which I've done before 2 years. So I'm from the Department of Mental Health Nursing. I'm a professor in Annai Sampoornam College of Nursing, Komarapalayam, Namakkal, India. And I'm here to present a very small paper, the impact of nursing care on biopsychological outcomes among patients undergoing spinal anesthesia in selected hospitals at Erode. So you all know about surgery. Surgery is a very big, the spinal anesthesia is a very big task of a client, I could say even. So this biopsychological outcome can be like anxiety. So patient may have anxiety. Even we start this, this outcome before the spinal anesthesia in the sense, even pre-operative phase itself, we start nursing care. We teach them what is exact surgery. We teach them what the exact skin preparation, what are the pre-medications, how to go for, how to take the food after, what are the food diet prescribed for that particular patient after surgery. And all these areas we touch as a nurse. So of course, in intraoperative period also, patient may have anxiety, and we also in this research we have showed some comic videos, and in post-op we have just to just enhance the abdominal gastric motility, we have just taught certain exercises. Next slide, ma'am. Yeah. So in the introduction, and perioperative nurse, in the sense it follows the 3 phase, preoperative, intraoperative, and postoperative. Nurse provides nursing care during all 3 phases. It's like preoperative anxiety is encountered at the rate of 60 to 80% in patients scheduled for surgery, and influences surgery, anesthesia, and again postoperative healing favorably. The surgical procedures and anesthesia place the patient at risk for several complications or adverse events or effect. The most common postoperative discomforts are nausea, vomiting, restlessness, sleeplessness, thirst, constipation, flatulence, and pain. So most often in clinical picture, what did I observe in the sense nausea? I've observed much more. Restless, I've observed much more. Sleeplessness, I've observed much more. Next slide, ma'am. Yeah, also impairment of gastrointestinal GI motility is an undesirable but inevitable consequence of abdominal or other surgery that delays recovery and may prolong hospital stay. Because we give spinal anesthesia, even we make the GI tract to paralyze. That's a problem here. Even the whole GI tract, all the lower limbs and GI tract is paralyzed here because of spinal anesthesia. So this gastric, back to normal, this gastric activity will be much more, it may prolong for a long time based on the recovery of the patient after surgery, in the sense post-operative period. And exercise stimulates postprandial motor activity in the stomach. As many literatures, they say that very active exercise, abdominal exercise after surgery could even retrieve back all the gastric mobility and gastric juice and gastric enzymes and gastric hormones back to normal, and patient can be very back to normal after even like 1 day after surgery. And in the stomach and small bowel, and its effect was related to the intensity of exercise, and abdominal exercise is easy to do and does not usually require any equipment. So this was really cited by Anila in the year 2019. Next slide, ma'am. The findings of the research generally indicated the anxiety caused by the unknown fear in the pre-anesthetic period. Operation experienced like an adventure, and the process generally completed with satisfaction. Okay, here you should know why that anxiety before surgery. I don't know how many could answer this question. Why a patient is getting anxiety, whether there is any biological fluctuation or any neurotransmitter link, direct link, or any other physiological link, or any other biophysiological link, or simply a social link. Can anyone answer this question?
Yeah, we have got a very interesting question from Dr. Sampoornam. And of course, we are hoping the answers from our attendees. Anyone from our attendees would like to answer?
Okay, I'll be the person to answer the same question, as I'll explain the context now. So this anxiety is a state, right? It is a psychological state, or it's an apprehension state of a person. And here, when a person is having a stimuli, here the stimuli is surgery. He's really very scared about surgery. Stimuli is surgery. So stimuli is very opponent to him. So here he is reacting as anxious. Why? In the sense, this stimuli, unpleasant, what to say, surgical or pre-surgical stimuli is ready to enter into his body or mind. So here, sympathetic nervous system stimulation will be much more high in the body. Sympathetic nervous system stimulation, his heart rate, his BP, everything is again high because of sympathetic nervous system stimulation. And the sympathetic nervous stimulation will have its own impact in the brain's neurotransmitter or biochemical, simply called GABA, gamma aminobutyric acid. And here it will have its own signal. The sympathetic nervous system will further give signal to the GABA, and this GABA will have its own fluctuation, which really creates anxiety in an individual or a person. It's the exact, what to say, science behind anxiety. So sympathetic nervous system stimulation, a protein signal to neurotransmitter GABA, and again patient is showing or experiencing anxiety. Yes. So here GABA is more, and the patient is experiencing anxiety, and we are nurses to help of the patient to drop or the calm down the symptom of anxiety. Even in the phase of intraoperative period, also patient will experience anxiety because of GABA. Even it starts from preoperative, of course, intraoperative, no more question. Literally, patient will have anxiety. We had a client, really, that client was very anxious during intraoperative period. He was talking with us after spinal anesthesia. Or 2 limbs have been paralyzed, lower limbs, and he is very conscious. You could hear what we are talking, and he is very anxious, and he's asking, I am literally okay, whether my unwanted, what to say, part has been removed, am I okay? I'll be all right. I need some oxygen. Can anyone talk to me right now? I'm a little tensed. So by the time we were talking to him, he was a little okay, and we showed some videos to him. Then he got settled all of a sudden. In the sense, while doctor suturing the area, he was unable to suture the area because of anxious person. The muscles became very, what to say, it was not that too good to put suture. We faced that, and we gave some muscle relaxant again to the client. We pushed an IV and we sutured the area. Of course, at present, we no more suturing. We do have surgical glue, advanced surgical gums available to just paste the layers of the skin, like epidermis, dermis, subcutaneous, and muscle layer. Very advanced science. But we faced, so this made me to take this research part. Again, nurse researcher identified the research gap for patients undergoing spinal anesthesia and its effect on biopsychological outcomes. Hence, research focused on nursing care for anxiety and gastric motility among patients undergoing spinal anesthesia. Slide, ma'am. Okay, methods. After obtaining written informed consent, patients undergoing spinal anesthesia who fulfill the inclusion criteria was recruited and enrolled in the study in selected hospitals at Erode. So quasi-experimental post-test vanillary control group design was used in the study. Purposive sampling technique was used to recruit these study subjects. Why we have made it as post-test vanillary in the sense, pre-test checking is mere waste because patient may have gastric immobility after surgery, we all know, and patient may have anxiety. So rather than checking, going for a pre-test, we have just shifted with post-test only design. Next slide, ma'am. The total sample size was 150 subjects, out of which 75 in experimental group and 75 in control group. And 150 was based on power analysis calculation, in the sense previous study, effect size calculation was made, and alpha power analysis, 80% power analysis was made, and it was divided into 75 in each group. And social demographic profile was also priced, like their age, like their gender, and all have been included and appraised. And nursing care comprised of pre-operative teaching module. Teaching module was given for 20 to 30 minutes, once on previous day of surgery through slideshow. An intraoperative video therapy was intervened for 20 to 30 minutes. An abdominal exercise was also given for 20 minutes twice a day for 2 days after surgery. Next slide, ma'am. So here in nursing care, pre-operative teaching module, again, it includes like we taught the subject about the nature, duration, and prognosis of surgery, and pre-operative screening test and informed consent, pre-medications, even surgical site preparation, a nil per oral state, because we don't put the patient under any food or any other oral before surgery, at least 6, 7, 8 hours. Spinal anesthesia, we'll just orient about what is spinal anesthesia, how far it will help out, and where it will be exactly anesthetized, or the two limbs, lower limbs will be anesthetized. Every information, each nook and corner, we just teach the patient. And post-anesthetic effect also, and post-operative diet, discharge plan, review, and follow-up schedule. Everything was taught to the patient for 20 to 30 minutes, once on previous day of surgery through slideshow. Slide, ma'am. Yeah, intraoperative video therapy. So it's just watching video during the intraoperative period by the subjects according to his or her preference from the video library, which comprises of various categories like comedy films, video songs, cartoon films, religious songs. I would like to highlight one more point here. Most of the patients, they preferred comedy films, and only few preferred cartoon films, and only one or two patients, they preferred video songs and religious songs. And the video was displayed by adopting portable DVD player with headphones, and video therapy was delivered to the experimental group subjects after they are stable in surgical table. Subjects were isolated from the surgical team by the privacy screen. Duration was for 20 to 30 minutes. Next slide, ma'am. Yeah, abdominal exercise. So it consists of abdominal breathing exercise, changing the position, and Vajrasana. Vajrasana is a part of like yoga asanas. And abdominal breathing exercise, the patient or the subject was placed in supine position and asked the patient to keep the hand over the abdomen, and instructed the subject to take a normal breath at the rate of 15 to 5 minutes, or 15 to 5 minutes. And again, changing the position, allow the subjects to change the position from supine to right lateral and give relaxation for a period of 5 minutes on the same side and repeat the same from supine to left lateral for 10 minutes. And Vajrasana with ankle and big toes touching the ground, ask the subjects to sit on their own heel and place their hands on lap and allow the subjects to breathe, concentrate their abdominal movement for 5 minutes was carried out, and duration was for 20 minutes twice a day for 2 days. Next slide. Next slide. Yeah. So control group received standard methods of care as usual routine care, and post-test was conducted by using Spellberger state anxiety inventory and of course modified gastric motility assessment scale and experimental and control group. And Spiegelberger state anxiety inventory, it comprises of 20 self-reporting statements. Each statement in the tool is rated on 4-point scale, not at all 1 and little 2 and somewhat 3 and very much 4. It consists of 9 positive statements and 11 negative statements. Next slide, ma'am. Yeah, the level of anxiety has been put as low, moderate, and high. And low, the percentage is 25 to 46, moderate 47 to 55%, and high 56 to 100%. And your modified gastric motility assessment scale, it consists of 4 areas such as bowel sound, appetite, defecation, and vomiting. And yeah, somebody is asking me a question. Amygdala has any role? Can I see that question once more? Yeah, whether there is any role of amygdala brain region which controls fear. Yes, of course. Yes, I agree with this point. Yeah. Yes, sir, I agree with this point. Amygdala and hippocampus. So in our brain, we have a special area called limbic system. Here, I would like to talk about limbic system. So limbic system is nothing but thalamus, hypothalamus, pituitary, amygdala, hippocampus, and midbrain nuclei. And as you said, I agree with this point. Amygdala and hippocampus are very closely related with emotions, especially even anxiety also. It is closely related with all types of emotions and feelings. Yes, any more questions? You can just put in chat. Okay, modified gastric motility assessment scale. Again, the gastric motility was graded into 3 categories. They are absent, irregular, and regular. Next slide, ma'am. Yeah. So level of gastric motility, absent is 0 to 33%, and irregular is 34 to 66%, and regular is 67 to 100%. Yeah, next slide, ma'am. Yeah, result. So PAT test and unPAT test showed statistical significance in reducing the level of anxiety and improving the level of gastric motility in experimental group and compared to the control group because of nursing care. And then this is a very small table I've just projected for you people. So in experimental group, the pre-test mean score is 45.1 and the standard error is 5.4 and post-test 31.1 and standard error is 4.3. And we can just make a comparison. When compared to pre-test, the post-test mean score is 31.1, which has really decreased or deteriorated or scaled down. And in control group, the pre-test mean score is 43.7 and the standard error is 4.2, and post-test, again in control group, the post-test mean is 41.4 and standard error is 4.0. And here that is very mild, marginal. It is not even significant, the mean post-test score. And PAT test score in experimental group, it is 10.38, which is highly statistically significant at the P probability level of 0.001. And in control group, again, it is not statistically significant. P is again 0.08, which is above 0.05, which is not statistically significant. And this hypothesis is actually rejected. And unPAT test, the value is 9.48 T value, and P is again statistically highly significant. P is equal to 0.001. So from this table, captions and steps, you can understand that this nursing care is highly significant in reducing the anxiety level in experimental group compared to the control group. So next slide, ma'am. This gastric motility, again, in experimental group, pre-test mean score is 5.3. Again, the standard error is 1.4 and post-test 10.2. And mean is, again, standard error is 2.3. And compared to pre-test, post-test, gastric motility has increased, and really patient is doing good in gastric activity. And in control group, pre-test 3.5 and standard error is 1.0, and post-test the mean score is 4.1 and standard error is 1.2. And compared to pre-test and control group, post-test is not that too high, not significant. Also, PAT-test, if you could observe the picture, the comparison you can make with PAT-test and experimental group 6.14, the PAT-test value in between pre and post-test scores. And I mean, we have taken 2 poster scores in the sense. And again, it's not pre-test, it's post-test, sorry. And 0.001, the PAT-test value says. And in control group, again, the post-test value 3.5 and second post-test value 4.1 and 1.2, the mean. And PAT-test showed 1.55, again 0.09, and unPAT-test is 7.58. Again, it is also statistically significant. Sorry, it's not pre-test, it is post-test, because we don't have pre-test at all. I've just pronounced it as pre-test. I'm sorry. You can take it as post-test 1 and 2. Okay, next slide. Yeah, discussion. So nursing care on biopsychological outcome reduce the level of anxiety and improve the gastric motility among patients undergoing spinal anesthesia. Yes, this result is consistent with an ongoing randomized clinical trial to investigate the effects of intraoperative music played during a spinal anesthesia operation on the patient's intraoperative vital signs, postoperative pain, and anxiety state or status. Next slide, ma'am. Yeah. So preoperative and postoperative anxiety, the intraoperative and postoperative vital sign and postoperative pain and anxiety of all groups were analyzed and was cited by Egypt in the year 2020. And again, one more citation in the year 2018 conducted a randomized control trial and to determine the effectiveness of 2 nursing interventions to control fear in patients scheduled for surgery. The intervention group presented a coefficient of changes in the fear control label controlled by initial NOC age and sex of 1.09. Again, P is very statistically significant here. Next slide, ma'am. Yeah, the coefficient of changes in the knowledge on therapeutic scheme label was 1.33. People who received nursing intervention showed a significant decrease in fear compared to those who received unusual care. So again, as I've done the research, again, the same literature also supported by some other research, which states that nursing care really supports and it reduces the fear and anxiety level of client at the time of a surgery, of course, in preoperative phase itself. The finding of the research generally indicated the anxiety caused by the unknown fear and the pre-anesthetic period operation experienced like an adventure, and the process generally completed with satisfaction. Again, the citation is by Ammal et al. In the year 2020. Next slide, ma'am. Yeah, these are all some of the references. Any question you can ask related to psychology or related to my topic, even transcranial magnetic stimulation. It's a very short topic I've presented now. Thank you so much for patient listening. And any questions can be asked right now. We can put in chat box also. I'm here to help you.